today, what we're going to be talking about is osseous resective surgery, apically positioned flaps, which I'm going to be called a displaced flap. We're pulling it into a different position than it was originally at. Bone grafting techniques and guided tissue regeneration. So now we're really getting into regenerative surgical procedures. Now, what you'll find with today's lecture is a lot of these different procedures can all come hand in hand. Okay, we can do osseous resective surgery and then finish it with an apically positioned flap. Most of the time when we do bone grafting, we're also following up with guided tissue regeneration. So just know they're not always necessarily completely separate procedures. A lot of the times these kind of all come into play, okay? But I'm going to go through the PowerPoint as separate procedures so that way you know exactly what's detailed within each one. Just know bone grafting, most of the time I'm going to keep it out of it too, okay? All right, so osseous resective surgery. Resective means we're removing. Okay, so we're basically removing bone, going in with the intent of removing bone. Okay? Which this can be kind of counterintuitive because we've spent our whole careers talking about wanting to preserve bone, and this surgery we have potentially remove it. And the whole reason behind that is because when patients have advanced periodontal disease, they can have really weird deformities happening within the bone. Vertical defects, one wall defects, osseous craters, and anytime there's deformities in the bone, the tissue tends to follow suit, and that's where we get into pocket. So basically, what we're trying to do with osseous resective surgery is this ultimately eliminate periodontal pockets. That's the main goal of this procedure. And the only way we're able to do that is by recontouring the bone, removing any of those defects, and that's going to allow for a more natural gingival contour, which is also going to reduce the pocket. Okay? And we'll talk more about these steps soon. Now, resective surgery is really only going to be performed on patients with mild to moderate periodontitis. This procedure is going to be contraindicated in patients with severe periodontitis. Why? They already have a lot of bone loss, right? Their teeth might already be mobile, so we don't want to go in and further compromise that support. But if a patient has mild to moderate perio, we're not necessarily 100% worried about the bony support. I mean, we still are worried about it, but comparatively to a patient with severe perio, we can get away with performing this on mild to moderate perio cases, and it doesn't reduce the prognosis of the tooth. In fact, it improves the prognosis of the tooth. Okay. But if we were to remove bone on patients with severe perio where they only have 20% of bone still attached, that's going to end up increasing the risk of tooth loss. Okay. All right, so our main objective, so like I mentioned earlier, we're basically going in with the intent of reestablishing the natural anatomy of our bone. Okay. It's, the attachment lines are still there. We're not regrowing the bone back in this procedure. We're just trying to reshape it so it's natural. And when we reshape that, like I said, the gingival towards it, so reshaped and reduces the pocket depth that way. Now here in this picture, this is a flap that was done. You can see the tissue's flat back. Here we have a big osseous defect here. Okay. And even around this implant, we have a circumferential defect where it's completely circumscribing the implant body. Okay, bone loss all around there and there. And what happens in these areas is when the gingival tissue over this, we'll just pretend it's this one here, with this defect, what happens is basically the tissue is also going to be dropping down that low. And that's where we get our pocketing from. So if we can find a way to smooth this out so the gingival tissue doesn't have that defect as well, we reduce pocketing. And even better is we can position that flap apically, which we'll talk about here more shortly, but if we pull that flap back as well and reposition it, maybe right here instead of up here, the pocket's going to go from maybe a 7, 8, 9 millimeter to maybe a 4 or 5. Right? So the whole goal of this is to eliminate our periodontal pockets. That's the whole goal. When we're talking about our flaps for access, our modified ligament, we're not, I mean, the benefit would be some pocket reduction, but we're not going in with the goal of pocket reduction. Okay, we're going in with the goal of accessing the area. This is going in saying, hey, we have an 8 millimeter pocket. I'm getting that down to the floor today. And I'm going to do it by trimming away the bone and pulling down that tissue. That makes sense? Okay. All right, so osseous resective surgery is actually one of the most predictable methods that we have or eliminating periodontal pockets. Okay, so I want you guys to know that. Most predictable surgical intervention for periodontal pocket. Okay? And the reason being is because we're cutting away the bone and we're pulling that tissue down inwardly. So we can assume that pocket will go from 8 to 9 millimeters to now 4 or 5. We're surgically forcing that to happen. Whereas with the plasma access, we can get an improvement in pockets, but we don't guarantee that. We won't know for sure that's going to happen. Even with regeneration, it's not 100%. So some terminology here. You guys know these terms already, so I'm just going to quickly go through them. But ostectomy and osteoplasty. So these two terms come into play when we're talking about our resective surgeries. Ostectomy, we're going in and actually removing the two supporting bone. We're moving that alveolar bone pocket. Okay. Now, this obviously is going to result in an immediate loss of attachment. Okay. Small units, but there's still going to be attachment loss happening, right? So it's for the greater good of eliminating pockets. Okay. Osteoplasty is reshaping the surface of the bone. Okay, so we're not going in and removing any of the two supporting bone, we're just kind of reshaping it. And you'll see in the video today, they have a really good demonstration of some thick buccal bone, and they basically go in and do osteoplasty on the buccal bone to kind of trim it down, make it a little bit smoother. That way they're doing it for the bone force nice and today. Now, these two terms go hand in hand. Okay, even though they're technically separate terms, when we're doing osseous resective surgery, ostectomies and osteoplasties are both happening simultaneously. Okay, but I do want you to be able to differentiate the technically speaking between the terms. Okay. All right, so let's go over our steps. And like I said, I have a whole video to show you what these steps look like. So we're just kind of going to go quickly through what this looks like here. So obviously we're engaging with flat. So we need to do horizontal and vertical releasing incisions. Vertical releasing is needed when we're going to be moving that flap around. Okay, so that's why it's not like the modified rhythm. It's not as conservative. We're going more aggressively with this one. Who remembers what the two names of our horizontal incisions are? Radicular is one of them. Spot on. Sulcular is the same as radicular. Starts with the knife. They're both horizontal.
That's the problem, right?
You're good. Okay, so our horizontals are the vertical and perpendicular incisions. Okay, when you touch on them, do you want us to just kind of know basically what it means, or when you use it? What they mean, I want you to know that they are horizontals, and I do want you to be able to identify certain incisions with the procedures. Yeah, okay. Which most procedures are going to use both of the horizontal incisions. The one that really varies is the vertical incision. These vertical incisions are only going to be used if we're needing to move that flap, if we're displacing that. Okay. So this one's going to be a full thickness flap, our mucoperiosteal flap. We have to basically flap back all of the tissue, including the periosteum, to access the bone. Because guess what? We're going in and removing the bone. We need access to it. Just like all of the other procedures, we're going in and we're debriding it. So we're going to get out that granulation tissue. We're going to debride the bone. The root surface is in it. Okay, just because this isn't technically a flap for access procedure, they're still going to go in and scale those teeth that are affected. Okay, we're already in there. We're not cleaning everything up. And then they're also going to remove soft tissue tags as well, just to make sure the tissue's nice and cohesive, so that way when they suture it in place, everything lays down nicely. Osteoplasty and osteectomy are going to be performed. And then they go back to basically the way osteectomies and osteoplasties are done. So they just literally take a burr, like they would use for hair removal, take their handpiece and actually just drill it. And then most of the time, once they're done with that portion, then they get heavy duty hand instruments and kind of straighten them up to make sure everything's nice and smooth. Okay. Now, what was that? This is the yeah. I know. So I always warn you guys even last semester, I'm like, you're gonna get into it next semester. So these flaps, like I mentioned earlier, are going to be very commonly displaced. That's why we want those vertical releasing incisions. We're basically taking the tissue from the gingival margin, where it's usually positioned right around the CBJ, and just pulling it apically on that tube. And the whole reason we position it apically is to reduce that body fat. Basically moving that tissue and pushing it down, so it's forcing the pockets to technically get smaller, even though we still have the same amount of attachment loss, but we're not regenerating anything. We're just reducing the contours and reducing the positioning of that gingival margin. Was that there one more? Exactly, yes. So we'll talk about once we get to our special consideration. That is the downside of this. Apically positioned slabs are going to expose roots for sure. Now, depending on the patient, like I mentioned, they're most commonly going to be displaced apically, but there might be instances where they will do a non-displaced flap. This completely depends on the patient. But most of the time, if we're going in with the intent of hospitalization with osseous resection surgery, that flap's going to be displaced. Okay. So if I ever ask you a question on that, I'll specifically say what is most common. Okay. Now, the other thing with this is because we're displacing the flap, we want to do what we can to make sure that the flap stays in place. Because as patients talk, they breathe, the sutures can kind of pull and everything can move around. So because of that, what they tend to do, what the surgeon will do is, hygienists can do this as well, is they'll place a periodontal dressing and we'll remove it. Now we get into the details of what periodontal dressings are in the fourth section of this chapter, so 2 weeks from now. But essentially, just think of that as almost like Play-Doh. They're going to take Play-Doh or clay, stick it on the surgical wound, and it hardens in place. And that prevents any type of movement from happening with the flap. Okay, it really helps stabilize that flap. All right, so apically positioned flap, like I mentioned earlier, this is going to be really ideal for minimizing the pockets. Okay, if we're going in with the intent of removing pocket depths, reducing pocket depths, this is going to be a very predictable way to think about them. And as you can see, the gingival margin, this is actually a field apically positioned flap. So the gingival margin is probably up here somewhere. Patient has severe attachment loss for patient involvement. So they flap this tissue back, putting everything up, and then intentionally push the tissue down so it's positioned maybe just a couple millimeters above that alveolar bone. So now the patient has full access to that perfusion. Yeah.
Is that anything you can do like later on to make it like more like healing, or is that
the downside?
and so it's just that's just how it is.
Exactly, yeah. So really, once we do an apically positioned flap, this is how it's going to stay for the rest of the patient. We're not going to go back through and try and regenerate this area or anything like that. That's all lost. And so that's why the surgeons are usually very reserved on the kinds of patients that are going to do this flap on because of that. Because it is not aesthetically pleasing. It's pretty rare to do this type of flap procedure on the anterior too, because you know patients are going to want to see after, so you know what I mean. So that's an excellent question. But the benefits of it is look how much easier that's going to be to clean. I mean, I hate cleaning for patients, but I probably wouldn't hate that. That's completely visible. That's nice, right? So this is going to lead to reduced pocket depth, but in turn, we have the root exposure. So that's why we always want to weigh risk versus benefit in this case specifically. So let's talk about the considerations. Now, as we mentioned before, we just mentioned, because the roots are exposed, it can be an aesthetic concern for patients. So surgeons, periodontists are not going to do this on a patient that is aesthetically driven, because it doesn't look as nice, right? We see our roots now. Right? Because the roots are exposed, we can have an increased risk for caries. So that's something to consider when your patient, if they do go through apically positioned flap and prosthetic surgery, then you have to be on their caries risk. And you have to be on caries prevention, making sure you're using fluoride, making sure you're brushing adequately, making sure they're coming to see you, nutritional counseling, the whole works, because obviously this area is going to be very prone to decay, especially in that. So education's key on that. Now, these patients, after their surgical procedures, can also experience hypersensitivity, which again makes sense. The roots are more exposed. Now, most of the time, that does not last long term. So that is the one thing that usually sensitive for 2 weeks afterwards, lots of cold sensitivity, but usually after that, things start kind of improving for the patient and everything kind of stabilizes in terms of their ventral tubules. But that's something you want to educate them on ahead of time too, you know, and during the process, making sure they're using sensitive. Okay. maybe even applying glue in those areas. Yeah.
Sorry, but, if the root is more exposed, does that also make it where like, I guess, there to combine easier, like from, I guess, like temperature and
No, you'd have to be doing something real wild for that. I would be more worried about like the risk of tooth loss or anything to do with trauma or anything like that. Yeah, they would have to be something incredibly crazy to have an increased risk for that. That's a great question. In terms of the other considerations here, so as I mentioned last week, we're always going to defer to the surgeons who will instructions. I promise you, if you're working with a good periodontist, they're going to be sending you a whole breakdown. Even if you're not in their office, if you're working in a general practice and you refer out to a periodontist, they're going to send your office an entire breakdown of everything that they did, which teeth were involved, what type of sutures were used, if they're talking about bone grafting, all of it. They send you so much detail. And then at the end of that, they'll tell you specifically what you can and cannot do as a hygienist. Most of the time, they're going to say, do not touch this area for 3, 4, 5, 6 months, even sometimes. Okay. So always defer back to the surgeon. You don't have a set timeline that says, hey, at that 3-month time frame, we can start probing that too. No, it has to defer back to the surgeon. They make the final call on when they want that probed. And most of the time, it also plays into the patient's healing response as well. So on the topic of healing, patients are always going to have to come back to their surgeon for post-op appointments. Okay? Most of the time, the first post-op appointment is scheduled a week out from their surgery. Okay, so 1 week out from the date of their surgery, they're going to get seen by the periodontist again. And what they're doing at that time frame is they're looking for healing. They're looking and making sure things haven't moved, things haven't shifted in appropriately. They're checking and making sure the sutures are still in place. Checking the periodontal dressing. And as hygienists, if you end up working in a perio office, you're going to be wrapped into the readall process. Okay. Like I mentioned earlier, we're going to talk about periodontal dressings in a couple of weeks. And you guys have the ability to place those and remove those. So if the periodontist is having a real busy day, and you say, hey, I have a readall, and we do that for me. I'll pop in and take a peek of the tissue, but I need to manage the periodontal dressing. I need you to remove any sutures. And we have the ability to remove sutures too. So always going to require a 1 week post-op. And like I just mentioned, if they use non-resorbable sutures, those are going to need to be removed. Usually a week to 2 weeks, depends on the surgeon and the type of sutures used. Okay. So if the patient comes in for a 1 week post-op appointment, if their sutures need to be removed at 2 weeks, guess what? They're coming out another week later. They're not into it out. Okay. Does that make sense? Right. Any questions on the considerations there for resective? All right, so healing occurs through primary, secondary, or tertiary intention with this procedure. Exactly. Okay, so primary intention, always associate that with sutures. If sutures are involved, we're looking for primary intention healing. And I'm basically saying that the wound, margins of the wound are very close together. Okay? Secondary intention. What's secondary intention? Yes, that's what I was looking for, granulation tissue. So basically with secondary intention, the margins of the wound aren't close to each other. Okay, so what they're able to do with healing is they basically create granulation tissue that bridges the gap between the wounds. Tertiary, that's the one you guys are there and have thought about the done, but yeah, exactly. That's the one where basically the wound is infected, so they like to leave it open for an unforeseen amount of time until it can heal, letting the wound breathe, and then they close it up at a later date. Okay, so really the only one you guys technically have to worry about, and if that's never in primary and secondary. Okay. All right, let's take a 5-minute break, and then we're going to watch our first video. Okay, so let's come back at 3:10.
So bad, but it's still so fun. Yeah. They come out. No.
Oh.
After it's like. Yeah, they're all good. And for the first few.
We're covered in blood from the freaking sweater. I like this one because it's really thin, but I always like if I'm wearing a sweater, I wear the jacket. Yeah.
Co-directed, once he died, the directors who took over, didn't. No.
They ended up in space. They forgot.
For the pile, and both of them. I didn't notice that. Yeah.
That is French.
Do we have question boards? No, right? No more question boards. Well, what? Question boards? The question boards is board reviews? Good. What? Good. Board reviews.
And 5.
For when? For next week? I don't think we did. No, because we had an exam and we have another. Yeah, I think we did. I'm not sure. Don't call me.
About disasters, fighting.
That, because they did a lot more back. So like the last one is. There's a lot of. It's good enough, so I mean, it's like. But they should have thought. They needed.
We're pregnant.
Yeah, it's like the 5th one. I would like the first 3, the 4th one. Yeah, and then they have, and this one they have like another new. Big Pedro Pascal. No, the fact we live now. It- Yeah. It's such a pop. Yeah, Keanu Reeves, love. Yeah. So, and. We bought. You know. We need a day.
Okay. What could be contributing to, like, what? Because I did on one blog and we had it. You know, so it's like, you're more.
Machete 3. They did it in space. What is It's like everything.
It does take the app away from my employment. It's always the best.
Right on. This video here, I should have recorded the video. Now, video. It's a little outdated in terms of the videography, but the content of it is really, really well done. You have to find a video that really surpasses it in terms of certain dimensions. That's what it's going to say. Which is just be wary. It's only the 1980s, it's all 10 of the 1980s. Okay. The other thing that you'll notice at one point in time in this video, they are talking about the osseous reflective surgery. And she stresses smoothing the bone and roots out, okay? That's the thought process, right? We're not going in with smoothing out cemented and removing cement. So just remember, you don't want to go in with the intent of removing cement. That's the only thing that's outdated. The rest of this whole video is completely spot on with everything that we just talked about essentially, okay? So this first section here, I think it's about 10-15 minutes of it, okay? And she goes over quantifications, recommendation, patient cases, all that fun stuff. It's really good.
Thank you.
Hello, I'm Dr. Joan Otomo-Portal. I'm a periodontist and a member of my national specialty organization, the American Academy of Periodontology. The Academy represents more than 7,500 members from the United States and around the world who have a stated interest in or limit their practice to the art and science of periodontology. The management of periodontal diseases is a process that takes place over the lifetime of the patient. As members of the dental team, the dental hygienist, dental assistant, dentist, and periodontist all have important roles in detecting, diagnosing, and treating periodontal diseases and maintaining oral health after the completion of active periodontal therapy. Being familiar with therapies that are available to treat periodontal conditions is important when treatment is recommended to your patient. For this reason, we have developed this educational video to explain some of the more common surgical procedures performed by periodontists. While we also perform other therapies, the surgical procedures you will see on this video are the foundation of surgical periodontal therapy. You will see 4 different procedures: pocket reduction, bone regeneration surgery, a soft tissue graft, and placement of a dental implant fixture. Our goal is to give you a better understanding of common periodontal surgery and how they can help your patients. As part of the oral health care team, periodontists and the American Academy of Periodontology are here to help you provide the best care possible so we can all improve the health of our patients. Before we begin, it is important to discuss the significance of having a comprehensive periodontal examination performed on each patient. A diagnosis and proposed treatment plan are presented to the patient based on the results of the examination. The dental hygienist and other members of the dental team play a critical role in collecting information to help detect periodontal conditions that may benefit from surgical intervention. Oftentimes, the hygienist will educate and prepare patients for their surgical and post-operative experience. Evaluation of the patient's periodontal status requires obtaining a relevant medical and dental history and conducting a thorough clinical and radiographic examination with evaluation of extraoral and intraoral structures. A patient needs assessment also should be conducted in order to clearly understand the patient's expectations for periodontal therapy. When combined with other clinical findings, the patient needs assessment helps the dental team propose the most appropriate treatment plan for the patient. We will present each of the 4 surgical procedures as a problem-solving exercise. Information will be provided about the rationale, including the indications, contraindications, expected clinical outcomes, and post-operative instructions for patients. The first surgical procedure is the periodontal flap and osseous resective surgery, known as pocket reduction surgery. When a patient who has already undergone phase 1 therapy, including scaling and root planing and oral hygiene instructions, still has deep pockets, furcation involvement, and bleeding upon probing, what do you do? What treatment options do you have to make sure that the maintenance program will be effective for the patient in the long term? One treatment option is periodontal flap and osseous resective surgery. Osseous surgery is performed for the purpose of obtaining flap access for the removal of otherwise inaccessible residual calculus and plaque, which are the etiologic factors for continued inflammation and loss of periodontal attachment. In addition, pocket reduction through osseous recontouring and apical repositioning of the flaps can create accessibility for plaque control by the patient and for maintenance procedures by either the hygienist or the dentist. This procedure is also indicated for the treatment of deeply decayed or fractured teeth that need their crowns further exposed to allow them to be restored. When completed for this purpose, the method is called a functional crown lengthening procedure. Contraindications for osseous surgery include medical problems, frequent surgery such as uncontrolled hypertension or uncontrolled diabetes. Other contraindications include inadequate plaque control by the patient, anatomical limitations to performing surgery, lack of cooperation by the patient, such as keeping maintenance appointments, or when the procedure would result in unavoidable aesthetic consequences. Our first case will take you through the step-by-step process of performing periodontal flap surgery to include osseous resection. Though bone and gingival tissues should fit snugly around the teeth, this patient's periodontal charting shows that probing depth interproximally, especially molars and premolars, are deep compared to the anterior teeth, making access for effective root instrumentation much more difficult, if not impossible. Upon the view of the radiograph, one can observe bone loss, interproximally premolar to molar, molar to molar, where ideal osseous levels should generally be 2 to 3 millimeters from the adjacent canal section. Probing depths on the buccal aspect of the involved teeth are minimal, approximately 3 millimeters, while interproximally in this quadrant we see probing depths of 5 and 6 millimeters. This patient's radiograph indicates that there is horizontal bone loss and furcation involvement. The bone loss is primarily interproximal, which is very common in patients with periodontal disease. Now we begin the pocket reduction surgery. This incision, called the primary incision, is designed to reduce the amount of diseased soft tissue and allow the flaps to be repositioned over the tooth roots and the osseous surface. The result is that it will make it possible for the patient to maintain good oral hygiene and for the clinician to provide effective instrumentation during the professional maintenance appointment. Keeping the area clean will increase the patient's chance of keeping her natural teeth and perhaps decrease the chances of serious health problems possibly associated with periodontal infection. Due to its shape, this incision is called a scalloped incision. It is designed to match the shape of the underlying root form, creating a soft tissue contour that is ideal for post-operative wound care and maintenance therapy. A wider scalloped incision on the distal of the tooth is performed because of the increased thickness of the soft tissue in the tuberosity area. Here, the clinician is lifting up the flap tissue with a periosseal elevator. This is accomplished by reflecting the soft tissue from the bone with the elevator. With the flap elevated, you can see that the crest of the bone is visible and that there is a remaining collar of diseased epithelium and connective tissue known as granulation tissue. Once this granulation tissue is removed, inspection of osseous contours is performed. Here is an intraosseous defect in the bone. In addition, ledges of bone are present on the buccal aspect of this tooth, and furcation involvements are present in the molar area. With the area fully degranulated and the osseous topography identified, you can now easily see the calculus and plaque on the roots, which must be removed in order to eliminate the periodontal disease etiologic factors and to promote a healthy periodontal environment. This is the primary reason why periodontal flap surgery is performed when sites do not respond well to non-surgical treatment. With a round burr, the clinician performs a procedure called osteoplasty, which shapes and thins the bone to remove the osseous ledges without removing the supporting bone proper. If left, these ledges prevent the soft tissue flap from adapting at a more apical area on the root surface. This process of osseous resection is done to increase the probability that the soft tissues will stay apically positioned over time, allowing for enhanced maintenance in the long term. This is the palatal view of the area, where again the clinician is shaping the bone to create a fluted surface and to gain access to the furcation. It is quite evident here that there is still a significant amount of calculus on the root surfaces, the dark area on the root. This clinician chose to use an end cutting burr to remove the calculus so as not to harm the root surfaces. During the osseous recontouring here, notice that there's copious water irrigation so that the bone is not overheated. Following osseous recontouring, it is necessary to remove the rough calculus on the root. As mentioned earlier, it is important to remove all the etiologic factors in order to ensure that the root surface is smooth, which promotes healing and discourages recurrence of breakdown. The clinician is using a chisel for this purpose. Others will use hand instruments and ultrasonics to plane root surfaces. You can now see that the roots look much cleaner. When root surfaces are smooth, the clinician can be confident that the roots are fully debrided and biologically healthy for stable periodontal tissue attachment. This view shows the surgical site after adaptation of the flap on the palate. Notice how it lies more apically on the root surfaces and is closer to the bone. You can also see that the tissue is at a more apical level on the tooth than it was initially, thereby reducing pocket depth. As a result, the previously inaccessible area on the root is exposed, allowing the patient and the clinician access to debride this area post-operatively and more effectively during the maintenance. Some clinicians may choose to place periodontal dressing, as you see here, to protect the wound and prevent food from disturbing the healing. The dressings and sutures are generally removed after 1 week. In the meantime, the patient should clean the area with a mouth rinse or salt water. The patient should not brush or floss the surgical site during this first week. This is post-operative healing. Some soft tissue cratering can be seen in between the teeth. This is known as interproximal cratering. As the tissue matures over time, this cratering will disappear. In the interim, the patient should use a very soft toothbrush and other aids as the treating clinician sees fit so as not to disturb the healing process. Here again, at post-op, probing depths are significantly reduced. There are less than 3 millimeters for all surfaces of the teeth in the surgical area. Studies show that with probing depth of 3 millimeters and less, most patients who practice good oral hygiene can effectively maintain healthy oral environments in conjunction with effective routine maintenance programs. This is the area where odontoplasty was performed to allow better access into the furcation during both the patient's oral hygiene at home and maintenance appointments. Palatal probing depths have also been decreased after surgery. You can now see that the tissues adapted very well to the root surface. Again, the patient must practice good oral hygiene to maintain this area. An interdental brush should be recommended to help the patient keep this area of the furcation clean. The expected post-surgical outcomes for pocket reduction surgery include improved soft tissue contours and health, adequate access for plaque control, reduced or minimal follicular depth depending on the objective of the procedure, adequate dimension of crown exposed for restorative procedures, and, of course, retention of the teeth with adequate function, comfort, and pleasing aesthetics. Let's revisit the key points of pocket reduction surgery. 1, the procedure is performed in cases of moderate to severe periodontal disease. The main objectives for this procedure are to gain access for the effective removal of residual etiologic factors, such as plaque and calculus, following scaling and root planing, and to reduce the depth of the pockets around the teeth, thereby reducing the places where bacteria can adhere and cause further periodontal destruction. Following surgery, the patient should be informed that the affected area may be tender for several days. In most cases, over-the-counter pain medication will be sufficient to relieve any discomfort experienced following surgery. In addition, it is imperative for the patient to keep this area clean. Patients should be instructed not to brush the area during the first 24 hours following surgery. Afterwards, the patient should be encouraged to gently brush just the top and sides of the teeth, being very careful not to get near the dressing that protects the gum. Keeping the area clean will promote healing and decrease the chance of discomfort. Patients receiving pocket reduction surgery should have an initial post-surgical visit to remove dressing and sutures approximately 1 to 2 weeks after the procedure. For patients with a history of periodontitis, periodontal maintenance visits at 3-month intervals have been found to be effective in maintaining the established periodontal health. Based on the evaluation, the clinical findings, and assessment of disease status, the periodontal maintenance frequency and treatment plan may be modified.
Any questions on that? How do you feel about that one?
They're just so invasive.
It really is. And when Dr. Wetman comes to, you'll hear from him, but periodontists really like to reserve that type of procedure for very specific patient cases, because there are a lot of downsides of it. It for sure is amazing when you do periodontal, we have root exposure now, we have sensitivity now. Patients might not be happy with how things look, so there's a lot of negatives that can come with that procedure, which is why most surgeons try and go more towards the regenerative route than the restorative route. But it is still a surgery that is still deployed today. It just depends on the patient case. Yeah. All right. So that is our osseous resecting. So now we're going to get into bone replacement grafts. Okay. So now we're starting to kind of talk into more of the regenerative, especially when we talk about guided tissue regeneration. Okay. So basically what our bone replacement grafts are is it's material that we can actually implant and press into the osseous defects to kind of try and stimulate more bone growth in that area. So show of hands, I think I asked this last week, but who here saw Dr. Wetman do bone grafting? Okay, excellent. The majority of you. We'll show you that other video today so you can kind of see what it looks like as well for those of you guys that didn't get to see what it looks like in person. This is a very, very, very common procedure though, not only even for periodontal disease, but let's say a patient had a tooth extracted because they had a and the impact is greater. So bone grafts have a wide variety of uses. Okay. Now there's 3 main terms that I want you to know when we're talking about bone graft material: osteogenesis, osteoinduction, and osteoconduction. Now, osteogenesis is basically saying that there's living cells within the bone material that create more cells. Okay, they cause more bone forming cells to form. Okay, osteogenesis there. And an example of that is an autograft, which we'll talk about here shortly, but basically a graft taken from the patient. Basically, they'll remove some of the bone on the maxillary tuberosity, take that bone and place it in the area of the osseous defect. And because that bone has living cells already from the host, it makes it very easy for it kind of trigger more cells to move into that area to regenerate bone. Okay. Osteoinduction is more of a chemical process. So basically, our bone contains bone morphogenic proteins, or BMPs. And these BMPs basically have the ability to actually recruit the area. Okay? They're not technically a living cell per se, but they do play a part with recruiting more cells to basically create bone in those areas. Okay? And one way that I remember that is induction inside. How bone morphogenic proteins are inside the graft, causing the bone to really more osteoblast. The last one we have is osteoconduction. Okay? And this one here is basically just utilizing the bone grafting material as a scaffold to have more bone cells, more BMPs that kind of go to the area and build onto it like a ladder. Okay? That makes sense between the difference between the 3. One's a ladder, one contains actual living cells that creates osteoblastic activity, and one has BMPs which recruit osteoblastic bacteria. Does that make sense? Okay. Now, the ideal bone graft is gonna have all three of those components to it. Okay, if we can have the living cells, we can have BMPs, and it acts as a scaffold, that's what we want. That's kind of, those are kind of what we look for when we're talking about bone grafting materials. But most of the time, a lot of the different bone grafts will only have one or two of these components. There are some out there that have all three. And that kind of plays into the surgeon selecting which type of bone graft material that they want to use. Because all of these materials I'm going to talk about here next are all accessible and able to use. It just depends on what the surgeon wants to do. Okay. But ideal is to have all three dimensions there. So let's talk about the four main broad categories of bone grafts. Okay. So we have autografts, which I just mentioned. In autografts, auto are cells, okay, taken from our own body. So this one will rely on either an extraoral or an intraoral donor site, which we'll talk about in more detail here in the coming slides, okay? The autografts taken from our cells. And these ones have the highest osteogenic potential. Which one is osteogenic? Our cell, the living cells, basically, okay? So highest osteogenic potential, which we like. Osteogenic is a good one to have. Out of all three of those potentials that I talked about, osteogenesis is really the main one. That's really, really good to have. If we can have all three of them, that's our ideal graph. But between the three, osteogenic is really good to have. Okay. Allografts. So this is going to be taken from another person. Now, it can be a living donor, but most of the time it's cadaver body. Okay. Now, obviously, because it's coming from a cadaver or another human being, these guys have to go through very intensive screening sterilization processes in order to make sure that the graft material is safe. Right? We don't want to be sticking the graft material in a patient that, from another patient that had like HIV or a virus infection or anything like that. Right? So we have to be really careful with that. Xenografts. So, from my experience, xenografts are where we tend to see the majority of our grafting happen. Okay, so xenografts are actually taken from another species, very commonly bovine, probably. Okay, so when I worked as an assistant, Golden Browns, they utilize bovine bone. Okay, we have to take care of that though and keep that in the back of our mind because some patients, some religions aren't okay with utilizing cows, right? So there's some patient groups that we might not be able to use xenografts on, and that's why it's nice to have alternatives. But xenografts are very, very commonly seen. As I mentioned before with the allografts, these also have to go through a really rigorous sterilization process, because obviously we're taking it from an animal, a dead animal, so we need to make sure that it's cleaned properly and that there's no cells that are present that could contribute to agents with infection or even rejection. And the last one we have are alloplasts. So alloplast, or I think of it like plastic material. Plastic, okay? It's synthetic materials. So another really, really good alternative for patients. The downside of that though is this has the least osteogenic potential. So autografts, highest osteogenic, alloplasts, least osteogenic. There's no living cells in these guys. So most of the time, this is just acting as the scaffold. Osteoconductive property. But it is a good alternative because basically having a scaffold there is going to make the body recruit those cells to that area. Okay. All right, so let's break down each of these in a little bit more detail. So autografts, those are the ones that we get from ourselves. The first portion I'm going to talk about are intraoral sites. Okay. So when we're talking about autografts, these are technically considered the gold standard because of that high osteogenic capability. Okay. Now, I mentioned earlier though that in my experience, at least a lot of surgeons and dentists will utilize xenografts, right? The main reason is because when we're using autografts, it requires 2 surgical sites instead of 1 surgical site. So that can be a turnoff for a lot of patients and surgeons. Okay. Now, if we do go through and get an autograft from an intraoral site, most of the time they're going to be harvesting from the maxillary tuberosity, or even the ramus of the main. Okay, so that's a big chunk of bone right there too. Okay. With this guy here, they do utilize osseous coagulum, and they do still use osseous coagulum in xenografts as well. And basically, all that is they take the bone dust from wherever they harvested it from, take blood from the patient's extraction site or flap area, however they're engaged in the grafting procedure, mix the two together, and that's what creates osseous coagulum. Okay, so it's just blood and bone mixed together. Okay? And that really helps with replacement, and replacing and packing the bone. Okay. Like I mentioned earlier, though, big disadvantage of this is the two surgical sites. So that's why a lot of surgeons don't deploy this, even though it has the highest osteogenic potential. It's a really great alternative. It's just a bummer that now we have two sites. Okay. The other thing to consider with this as well is depending on the patient and how much bone density they have, it might be really difficult to get enough bone to fill in the space, right? So that's another reason why surgeons might stray away from this, especially if they're extracting on a molar, or if there's a huge periodontal defect that's encompassing 3 or 4 teeth, they're going to need a lot of bone in that patient to be able to pack in that area. So that can also be a little bit of a threat. Okay. Questions on the autographs from intraoral? Extraoral, these ones you don't really run into, okay? Because taking an autograph from an extraoral site even further increases the risk of complications after surgical intervention. So autographs from extraoral sites, when you do see them, most of the time it's taken from the hip, right? And I personally don't know any surgeon off the top of my head that is going to be like, hey, I'm going to get you one down in the hip and access your hip and remove some of the bones. Right? That's like a different surgeon and say there was a honestly, I do not. I would not think that they're going like do surgery on your yeah, exactly. And I honestly don't know the answer to that. I really don't. Just because again, this is so rarely used. I have zero experience in this one. You think zero experience, and this is just this is very, very rarely used. Just because one of them gets post-op populations. Not only worried about intraoral sites that we transplanted it to, but now we have to manage this extra well site, right? And the same thing as I mentioned earlier as well, it was going to cultivate that bone from the site as well. Bone material to actually wrap those. Not very common because you guys know they're kind of like this at all. Okay. But if we do have an autograph from an extraoral site, I want you to know it's associated with it. And you're not going to do this one. This is very intensive issue. Okay. All right, so now let's talk about our allografts. Our allografts is the bone that's pulled from donors or cadavers. Okay, most of the time it's cadavers, so it's referred to as freeze-dried bone allografts (FDBA). Now these guys here can be considered calcified or decalcified. Now calcified is just a regular FDBA. Okay, basically they take the cortical bone from a donor cadaver within a couple hours of death and go through a sterilization process. Okay, so they don't really do much to the bone besides treating it for sterilization of viruses. Decalcified, so DFDBA, decalcified dried bone allografts. Same process, they're basically harvesting it from the cadaver very shortly after death. But what they do is they actually demineralize the outer layer of that bone. And when they demineralize it, what that does is that exposes those underlying BMPs, the bone morphogenic proteins, which improve osteoblastic activity, which ultimately improves osteogenic potential. Okay. So having it decalcified is nice just because those BMPs are exposed and it increases the osteogenic potential. Okay. So the steps for processing these materials, they're not just harvesting this material from any cadaver, right? They're going through and looking at the medical history of that person that passed away. They're making sure they don't have any eye disease risk factors present. They're testing for viruses. They're testing for all sorts of things to make sure that this is safe and has a low risk of transmission of diseases. Okay, so even though it sounds kind of weird that we're using cadaver bone, it's safe. They go through a very rigorous testing process. Okay. Questions on that one? Alright, let's talk about bovine bone now. So bovine derived bone is our xenograft. Okay. Same thing, since we're pulling from another species here, similar to the allografts, they're gonna go through a rigorous process. They're gonna wanna remove all types of organic components from the bovine bone to reduce the risk of infection. Okay, egg cells are a little different than our cells. Their bone structure, the reason we use bovine bone is their bone structure is very similar to our cells. So this is very, very, very successful in terms of grafting material. We just have to make sure that we don't kill all the cells in it, so there's nothing that can increase risk of transmission. Okay, so because we basically remove all of the organic components, there's no osteoblasts, there's no living viable cells in this material. There's not even really DNPs present. Okay, so what this does is this essentially is osteoconductive in nature. So it's just acting as a scaffold. Okay, the sterilized bone material that's getting placed in that area, and that's going to trigger the alveolar bone to kind of come in and fill in that area. Does that make sense? All right, so now let's talk about our alloplasts. So these are the plastic and synthetic materials. And there's a couple different ones that we'll talk about, three main ones that we see, but there's a wide variety of different synthetic materials that can be utilized for bone grafting. The first one is referred to as plaster of Paris, and that's a calcium sulfate material. And it's really nice because it's porous, and having the materials be porous acts as that scaffolding, right? So having a porous material that we're packing in is basically creating a ladder or a bridge for more bone cells to move into. Okay? Nice thing about that as well is it's very biocompatible, so we're not worried about irritating tissue or causing issues or anything like that. And what's nice about the plaster of Paris is the calcium sulfate is actually going to resorb after a couple of weeks, which is great. So it's basically acting as a scaffold, acting as a ladder, holding everything up. Bone cells are going to move in, and once the bone cells move in, that calcium sulfate is involved in this. It's just the actual patient called, which is nice. So this one is really acting as the osteoconductive potential. We don't have the ability to prove osteogenic potential with this stuff, which makes sense. It's not a living material, right? It's plastic, calcium sulfates, synthetic, right? We can also use bioactive glass, right? Which when you hear the term glass, you're like, ooh, that sounds kind of weird. But this is basically just ceramic. Okay, so ceramic material that has calcium salts in it, phosphates, and silicon dioxide. Now, this one does have the ability to attract osteoblasts to the area, which again is forming a bone, and it does that through the scaffolding as well. Okay, so that scaffolding, that little ladder being in place, is going to trigger the bone to move osteoblasts to the area to reform. Okay. Lastly, we have calcium phosphate here, and this one's basically a hydroxyapatite or a tricalcium phosphate. So again, osteoconductive potential. Notice the trend there. Alloblasts are basically just osteoconductive in nature. They're acting as the ladder. Okay. Now, calcium phosphate, we don't run into this one being used very often because there's a little bit of some downsides to this one. Okay. So tricalcium phosphate is poorly resorbed. Hydroxyapatite is not resorbable at all. So basically, when they place this material in, it's not going to resorb away. And the bummer of that is that it can lead to the material actually becoming kind of surrounded by collagen and causing issues within the tissue. And so because of that, we're not super fond of utilizing the calcium phosphate. And we don't want to see tissue issues in the tooth long term because it's hanging out under different gums. Okay. Questions on that? How we doing? Right? Raise your hand. Right. Okay. All right. We'll take one here in a couple minutes to do a couple seconds. So healing, basically what we're seeing with our bone replacement grafts, we see a partial rebuilding of alveolar bone. Partial. And it's not going to be full blown back to complete health, but nothing ever happened at that site. But we do have really good promising results that we can see with these patients. But the thing with this is it's not gonna result in complete reformation or cementum and PDL. In fact, they aren't even really able to determine if the PDL fibers actually embed into a new bone that's formed. And that's why this is one of those procedures that's not technically considered regenerative in and of itself, even though we're getting more bone growth in the area. We're not seeing cementing growth, and we're not getting the PDL fibers embedded to that bone. Okay, so even though the bone is there, it's gonna act as support for the tooth. It's not actually embedding into the tooth. That makes sense? The other thing that is nice though about this bone graft is that a lot of research has been done about bone grafting. It really has. And they've shown through a number of years of research that basically patients that undergo bone grafts are going to increase the benefit of prognosis essentially in the tooth long term. Okay. It's going to help keep that tooth clean out for hopefully the rest of the patient's life. So it really does have a lot of good benefits to it, for sure. And like I said, bone grafting is something that's definitely done when we extract the tooth for infants as well. So it goes beyond the periodontal. Okay. So any questions on that healing there? Okay. So are the PDL fibers, are you for sure able to definitively say that PDL fibers are embedding bone? No. Okay. We can't definitively tell that. The reason being is the only way to tell if the PDL fibers embed into the new formed bone is through histological analysis. And if we're doing histological analysis, that makes the patient die. And we're having to come away and look at another slide, which that's not really feasible in research film, right? So that's why it's difficult to prove if there's PDL attachment there. Okay. All right, which bone grafting material has the highest osteogenic? Autograft, yes. How about the lowest? Allograft. These other two guys kind of fall into, okay? What type of bone grafting material involves the use of synthetic materials? Allografts, okay? So notice how allografts and allografts both start with allo. One way to remember that, plastic, or plaster in Paris, okay? So that's the main way to differentiate. Synthetic material or your allografts. What's the correct term to use when describing a graft material that acts as a scaffold? Conduction. Induction is the one that has BMPs inside of it. Yep, BMPs are inside osteoinduction. Osteogenesis is the best one that has living cells. Questions on that? Okay. Do like 2 more slides and we'll watch our considerations here. So similar thing with our last surgical procedure we just talked about. If we're using non-resorptive sutures, they gotta come out. They gotta come out in the year 2. Okay. So most of the time we're gonna see a 1-week follow-up with these patients as well, just to make sure that everything's stabilized, the wounds started healing, the sutures are still in place, things like that. Similar with last surgical consideration as well is we're not really going to be touching that graft site for some time. Okay, and again, this one very specifically we want to refer to the post-op instructions by the surgeon, because it depends on what type of graft material you use. So again, we're not going to say, hey, at that 3-month mark, we're good to program. We can look back on what the surgeon said. They might say 6 months for these bone grafts. Okay, might say 3, might say 6, might say 1. Got it, but keep that in the back of your mind. And biofilm control is always going to be essential after surgery, just like with every surgical intervention as well. So usually at that 1-week post-op, we kind of reassess that area, and if there's any biofilm building up, we're moving it at that time, and then we're forcing patient away check. Most of the time, a couple days after we do bone grafting, they're not really going to be playing with that area around. But after that, once we see it at least 1 week post-op and things look good, then we really start reinforcing it. So, okay, well, the tissue's starting to heal, so we can start brushing through it, using the water. Okay. All right. So like I mentioned before, even though this whole chapter really focuses on periodontal reproduction, bone grafting is super common with the kids as well. So if you have a patient in your care that has a hopeless prognosis on a tooth and that tooth's extracted and they're starting to talk about implants and things like that, they're gonna need a bone graft. Now, this is bone grafting can be used with extractions of implants, no periodontal disease involved, or it can be used for treatment of periodontal disease. Periodontal defects. That makes sense? Okay. All right, let's watch this quick little video and then you guys can take a little break. So this woman here, her name is Whitney, I believe, which means tooth talk or tooth talk. Yeah. If you guys have an Instagram, she's amazing. If you guys have Instagram, she does some really good videos. Not only are they educational, but she also has some good humor to her as well. You know how we all have different patients' experiences. She really plays on that, which is fun. This video here, the beginning portion of it is really good for you guys to hear, just kind of reiterating everything I just talked about. And what I like about this video is this also is kind of geared towards patients. So then you'll hear her talk almost like she's talking to her patient about what to expect. And I want you guys to pick up on that verbiage, because guess what? You can use that verbiage with your patients. Because if the dentist comes in and says, hey, we're gonna extract this tooth, do a bone graft, or do an implant. Any questions? Nope, you're good? All right, and they're gonna walk out. Patients then gonna look at this like, oh my God, that sounds terrifying. What should I expect, right? So that's where you guys are gonna come into play, okay?
What is a dental bone graft and why would you need one? Let's talk. Hi everyone, my name is Whitney and I'm a dental hygienist here to talk about bone grafts. So a bone graft, sometimes referred to bone augmentation, is where a new bone from another part of your body, a donor, an animal, usually cows, or synthetic bone, regardless of where it comes from, new bone is placed into your existing bone, programming your body to build more bone in that space. As the graft fuses and integrates, it makes your existing bone stronger and denser. It's like triggering a natural reaction that's built into your body, strengthening your bone. So why would someone need a bone graft? We rely on healthy, dense bone to keep our teeth deeply rooted and secure enough for chewing, right? So grafting helps reinforce areas of our mouth where tooth mobility, loose teeth, or tooth loss is a risk. The three most common reasons you would need more bone height or more bone density are: one, for dental implants. Just like teeth, dental implants need bone to fully surround them in order to hold them in place. So if there is not enough bone in your jaw to hold in an implant, you can't get an implant. Oftentimes bone grafts are needed prior to getting an implant. Two, gum disease. Gum disease, aka periodontal disease, physically destroys the bone around the teeth. However, if you catch the infection early enough, you can stop the spread of the disease. Unfortunately though, if it's too late and too far gone, the bone won't grow back on its own. So if you're running the risk of tooth mobility or tooth loss, a bone graft can often help reinforce your smile. And three, bone loss. Bone tends to shrink away after a tooth goes missing. Like if you've had an extraction for some reason, the shrinking bone may not seem like an issue if you're not getting an implant there, but it will affect the healthy neighboring teeth next to it. Okay, so we know what a bone graft is and why someone might need a bone graft, but now let's talk about what you should expect at your appointment if you're about to get a bone graft. Your actual bone graft appointment usually gets combined with other treatment like an extraction, periodontal surgery, or a sinus lift. So like, for example, you'll most likely be scheduled to get your tooth pulled plus get a bone graft at that same appointment. And on the date of your appointment, you can plan on your dentist numbing the graft site just like they would during any other routine procedure. Most of the time, nothing more than a local anesthetic would be needed. You can be completely awake and drive yourself home afterwards with nothing more than a numb cheek and lip. I do have a video all about the different sedative options and different dental anesthesia options if you're curious to learn more about additional anesthetics that can be used. Either way, whether you're asleep or awake, for the graft to be placed, a small incision will be made so that the bone underneath can be accessed. Then your dentist will place the graft material directly on the exposed bone or inside of the open socket. After that, the tissue is closed up over the graft and sutured in place. Then comes the healing process. Grafting doesn't just take overnight, right? You have to let your body integrate with it where it fuses the graft in place and forms new bone around it. This process may last anywhere from 3 to 6 months, but don't worry, you won't be feeling it that whole time. If you had a tooth extracted, you might experience some tooth sensitivity, tenderness, or minor swelling for a few days. But once it's been a week, you won't have any discomfort anymore. Internal healing will be taking place for the next 3 to 6 months, but you won't feel it that whole time, like I said. Your dentist will take x-rays at various intervals to measure the bone density and make sure things are healing properly. And you can set yourself up for proper healing by following your dentist's home care instructions the days immediately after your bone graft surgery. You'll want to take things easy, plan to eat soft foods and not to chew on that side of your mouth for a couple days. And depending on what type of stitches your dentist used, they might be dissolvable, or you might need to go back and have the sutures removed in a week or two later. In all, the procedure itself won't be painful because, like we said, your dentist will warm you up. And depending on what you had done, you might feel a little tender afterwards, but as long as you pay careful attention to your dentist's home care instructions, you will recover in no time. And just a little insight to the home care instructions, which would be for the first few days, they're generally things like avoiding hot, spicy foods, not drinking carbonated, caffeinated, or alcoholic beverages, not drinking with a straw, no smoking, applying an ice pack to that side of your face on and off for the first 24 hours, and keeping your head elevated for the first 1 to 2 days. They might also recommend you to take medication as prescribed, such as an antibiotic or over-the-counter pain relievers, depending on your dentist's instructions. Again, those are just some of the common suggestions your dentist will have. Be sure to ask them exactly what they want you to do for a quick recovery. And lastly, if you want to learn more about the cost and whether or not insurance covers bone grafting, I will link my bone grafting article with a pricing list so you can get a better idea of what the overall cost would be. I hope this video helped you. Please like, subscribe, and turn on your notifications if you did. If you want more teeth talk, come hang out with me on Instagram at Teeth Talk Girl. Peace, love, and teeth.
So these are the types of videos I'm looking at patients. That's not. Okay.
She got her entire like motivation from Crash Course and telling me exactly like him.
So yeah, I can totally see that. She's great though. I really like her. She's one of the main ones I follow on Instagram. Jerry RDH is another one. As well. You guys are ever looking at my website. All right, let's take a 5-minute break. Let's come back at 4.
I can't with you to do it. Why is it so big? Nine? Como me duele,
Yeah, it's like you super bad.
Pero creo que no,
I'm so sorry.
por evitar que se muevan
Not the spray seating.
No, ella no me dijo por eso,
It's almost like a mouthwash.
pero sí que me
Mouthwash.
sentido.
And
Pero por eso que ahora mismo esas cosas. Una farmacia. Toallitas, que tienen, puede ser de frío o de caliente. So, yo creo que una es puede comprar también y ponte las buenas. Porque sí, 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 y compré una almohada que es
Hair.
Why are you doing the first? Angela. Sí, eso está. You win. Hey. Girl. This one's hard to use because it's super big. Super big. Oh. No, entonces vuelvo yo. Hey, this is fun. When I was kindergarten, there was like a lady team. And I remember one year she went to get, there's like the coffee machine, and she fell. And broke herself. And I thought she'd die. I cried at the car, like, oh. Oh my god, she'd be so pain. What did your boss say? He was just help me. I really thought he died. Like, I didn't know what that meant. I was like, I'm never gonna see her again. Yeah. Yes.
Talk about today is guided tissue regeneration. And this here is our regenerative therapy, okay? Regenerative regeneration. Now, at the beginning of this lecture, I mentioned how some of the procedures all kind of coincide with one another. This one's a prime example. So oftentimes when patients undergo bone grafting, they're usually also getting guided tissue regeneration episodes. Okay, so just know bone grafting usually is also an incorporation to that as well. Okay, so here with our guided tissue regeneration, GTR, this one's the one where we're looking at regeneration of cementum, PDL, and alveolar bone. Okay, which again is why most of the time they tack this on if we're already trying to regenerate the alveolar bone. We'll go through GTR as well to make sure we get cementum and PDL back as well. Okay. So what GTR requires is the use of a physical barrier membrane. Okay, and this membrane plays a very, very important role in the regenerative process. Okay, and over here you can see a good example of what that membrane is. Just this little white piece of paper almost. And what that's doing is that's going in and kind of dictating what tissues it wants to move into the area. Okay. Epithelial tissue or epithelium grows very, very, very quickly. Okay. If it's a race between epithelium, alveolar bone, connective tissue, epithelium is going to win every single time. So what this membrane is basically doing is when it's placed in, the epithelium is going to be sutured over it. It basically physically stops the epithelium from going into that loop and gives the alveolar bone and PDL cementum a chance to really regenerate. If that barrier is not there, the epithelium is going to move into the area that we're trying to get the bone to grow into. Okay. Does that make sense? Very important role for this guy here. Now, what we tend to see is that we have undifferentiated cells from the PDL. These undifferentiated cells are almost like stem cells, okay? So the PDL basically has these cells that can then become differentiated into alveolar bone. They can be differentiated into more PDL fibers and even more cementum. So those cells play a very, very important role. And again, those are the cells that we're trying to give an opportunity to heal and migrate into the wound area compared to just the epithelium. Does that make sense? So the regeneration is actually coming from the undifferentiated cells from the PDL. That's where our regenerative process is coming from. That's why the PDL is such an important anatomical component, basically. Okay? Questions on that? Okay. All right, so here's a good little diagram to kind of give you a good visual. So here we have epithelium, we have connective tissue, we have bone and PDL, all trying to win the race.
Hear that?
That was one. Sound like a slice. Get out.
So here in this diagram, you can see that we have the epithelium, connective tissue, bone, and PDL all trying to win the race to migrate and attach and fill in that area, right? And we don't want this stuff moving in first. We want to give these areas, especially the PDL, an opportunity to fill in before the epithelium migrates down, okay? So over here, you can see what they did was they placed in the barrier membrane, right? This little big thing here, and that's physically preventing the epithelium and even the connective tissue from moving in first. And it's giving these cells, PDL cells, undifferentiated cells from the PDL, an opportunity to migrate and turn into osteoblasts, fibroblasts, cementoblasts, and that's where we get the regeneration from. Okay? And over here on the side, you can see it looks like a healed area where they have that membrane in place. They have the bone that grew back and the PDLs that grew back and prevented the connective tissue from forming. Don't get me wrong, we love our connective tissue, but not with this. We want to keep that stuff away, we keep the epithelium away to give our more structure supporting tissues a chance to heal and regenerate. Okay. So the ultimate goal of GTR is regeneration. That's our whole. And if we can get regeneration, we tend to get pocket reduction as well. So it can give us an which is nice, without actually resecting and removing the tissue. Now, so we mentioned the osteoresective surgery earlier and how predictable it is. This guy here is not entirely predictable. Okay. Now, most of the time we do get really, really good results from this, but it's not guaranteed every single patient. You're going to have 100% bone growth on that. You can't make statements like that. So it's not entirely predictable. Depends on the surgeon, post response, depends on post-op. So there's a lot of different variables that come into play with this. So not entirely predictable. Osteoresective surgery is getting more predictable in this time here. But this is really, really, really a great opportunity for patients to have the ability to regenerate that tissue and not lose their tissue further. So a lot of surgeons and the general dentists engage in GTR. Okay. Our whole goal is regeneration. So here's some steps here, and just like with the previous osteosection, we're wanting to do a full thickness flap. We need access to that bone. Okay? Just like our other surgical interventions, we're going to debride the osseous defects, debride the roots, make sure everything's nice and clean. Then they're going to take the barrier membrane and they're going to actually trim it to specifically fit that site. Okay? That way it's able to seal up the bone graft essentially. Most of the time we place the bone graft, once we access the sites, they're going to place a bone graft, place the barrier membrane on top of it, and then suture it up. So that's really the big difference between this and just bone grafting. This is bone grafting, but added on with barrier membrane on top. Membrane you can see here in the face. we have in our primary extension here. And then the flap's gonna be sutured in place. Now, this flap, we're not like opposite of osseous resective surgery. We're not gonna be positioning this as a, we're going in with the intent to regenerate. So we're gonna make sure it's positioned thoroughly. It's gonna be completely covering the barrier membrane and hopefully getting that regenerative process happening, okay? All right, so our materials that we can use, we have resorbable and non-resorbable. 9 times out of 10, surgeons are gonna be using resorbable. Okay, they don't have to cut that tissue back open to remove the membrane. That's just unnecessary trauma, especially when we have really good products out there that are resorbable, okay? So resorbable are gonna be preferred by most clinicians because we don't have to bring them back for it. The only downside of them is they're lacking in rigidity and form, like the structure of the barrier membrane compared to the non-resorbable. So our non-resorbable membranes are actually going to be embedded with little titanium strips. Okay, that's why we have to go back in and remove it. That titanium is not being absorbed. But the nice thing about that is it really helps prevent flaps. It really gives us a good form for the tissue to kind of adapt over top of it. But again, we really like the resorbable, so these guys can play most I personally have never seen non-resorbable ones. Okay. And here's a really good example of what that looks like here. So this one is a resorbable membrane here, placing it over the site, and then they're suturing it up in place. So ideally, we don't have any of that membrane exposed. There are some times when patients will come back in for their post-op where some of that membrane will be exposed a little bit. We'll talk about that here in a couple more slides. Okay. This is what we should have like. Okay. Again, mentioned that's very commonly used with bone graft. And mostly kind of great bone graft for replacing that barrier membrane on top. So here's a good example of what this looks like with the BTR. So off on the left, here we have an osseous defect here. Okay, it looks like a free wall defect, like a facial wall, a proximal wall, and a dual wall. Okay, and basically what they're doing is they're going in and filling it with bone. Okay, so here's that bone material, and they basically hack it into place and push it down. Again, you'll see that in the video. Okay. Then they're going to place a barrier membrane, which this one's kind of hard to see. It looks like it already is covered in blood here. They have a little barrier membrane that's going over top of that bone graft material, not only to hold it in place, but to also try and prevent the epithelium from growing in and giving this bone a chance to grow. Okay, then they suture everything in place. So that's the post-op. And notice how it's positioned firmly. We are not displacing this flap by a previous. If this patient had recession, let's say this tissue usually is sitting down here, we're pulling that tissue up thoroughly. Okay, we really want to try and get that tissue out of its natural positioning so that it looks regenerated, it looks healed. All right, so just like the other, notice the trend here with the surgical post-ops. We're seeing these patients back after. So anytime you send your patient to a periodontist, they're going to be seeing them after the surgery is done. Again, if we use non-resorbable sutures, they're going to be removed at that time frame, usually 1 to 2 weeks after surgery. Same thing as I mentioned before with our bone grafting. We're not probing for several months minimum, and always defer to the surgeon's post-op. So I'm not giving you a set timeline saying 4 months we can grow. I'm not even saying in 6 months we can grow, like a year. Nope, I'm not saying any of that. You have to defer back to the surgeon. That's their real master determinant. Like I said, there's not like a set standard for when it's safe. It depends on the patient and the surgical technique that's used. Now, earlier I mentioned that sometimes we can have exposure of the membrane. So if your patient comes back to you and at that post-op, let's say a little piece of the membrane is just sticking out right here. Okay. What we want to do is just pay attention to that for the surgeon, make sure the surgeon's aware. And at that point, we're not going to go back in and remodel the tissue and resuture it, right? We're not doing anything crazy like that. At that point, what we're just trying to do is prevent contamination. So it's just bioform control at that point. We want to try and prevent bacteria from going into that really grafted bone area, bone tissue. And so over time, if there's exposure of membranes, which you will see, I've seen it more times than I can count, it happens. It's not any issue with technique, it's just a patient feeling that ties into that. Most of the time, we just have them irrigated some chlorhexidine very gently, just keeping that area nice and clean while the tissue finishes healing. Okay? That makes sense? Right. So what kind of feeling are we gonna see after GTR? Okay. You guys are overthinking this. This one's gonna be regeneration.
Oh.
Regeneration, I know. Ready?
About like a mixed area.
So this one is just gonna be regeneration, or stimulating the growth of new bone, new cement, and new heal.
You go over
So repair is gonna be almost like a scar tissue, okay? That's the formation of the long-junctional epithelium. Reattachment is basically happening, I haven't given you too many examples of this yet, we'll get into this more next week. But reattachment occurs when a patient is undergoing periodontal surgery or aesthetic research, they have recession. No disease is present, we're flattening the tissue back, but we're not actually removing any disease tissue, so it just basically reattaches. New attachment is when we have disease that happened and we remove that disease tissue, and instead of undergoing repair, we're getting new attachment of the epithelium. So it's not a long junctional epithelium, it basically supports new attachment of this irregular junctional epithelium. And then regeneration is the only one that's going to give us new bone, new cementum, and new.
That was great, like all of it.
Since everyone was quiet, I'm like, wait, let's go over this for some things. Now, the way to remember that this one's regeneration as well, if there's regeneration, right? Guided tissue regeneration. Regenerative. Okay. Great. Simple round out. All right, so let's watch our final. Now, same video, but this one's going to show a bone grafting procedure with that guided tissue regeneration. So you're going to place the bone graft and put the barrier membrane over top. That barrier membrane is really the only difference with PTR as well. It's on the back of your mouth. We're putting the membrane over that. Okay.
Our next patient presents with a residual deposit after scaling and movement. This patient differs from the first case, which exhibited horizontal bone loss, in that we have the presence of an angular osseous defect detected by both clinical and radiographic means. What are the treatment options for this type of case? An effective treatment option is a bone graft with guided tissue regeneration. Whenever possible, the optimum goal of periodontal therapy includes regeneration of lost periodontium, including alveolar bone, cementum, and periodontal ligament. This is the rationale for guided tissue regeneration. Indications for these procedures include infrabony defects pronounced and flap supercation defects with a significant vertical component. As with flap access surgery, this procedure allows access to remove plaque and calculus in areas not accessible by closed divisions. Some of the contraindications for bone regeneration surgery include poor patient compliance and or oral hygiene, smoking, systemic conditions such as immune system disorders and uncontrolled diabetes, active endodontic lesions, and excessive tooth mobility. We will now discuss the regenerative surgical procedure for this case. The radiograph shows an infrabony defect of approximately 7 millimeters. You can see the extent of bone loss between the two arrows. The recommended treatment is the bone graft procedure. This course of action will promote the reformation of cementum, periodontal ligament, and bone, which has been destroyed by periodontal surgery. In this case, the clinical probing depth on the mesial of tooth number 8 is approximately 7 to 8 millimeters, and has approximately 7 millimeters on the facial aspect. The adjacent central incisor is probing normal. From the radiograph and the clinical picture, the clinician can determine that there is bony defect localized to the tooth. For comparative pocket reduction we discussed earlier, the incision is different in design. This is called an intrasulcular or crestal incision because of its shape. The purpose of this type of incision is to retain as much soft tissue as possible, in contrast to the previous resective procedure, which removes diseased tissue. Though the surgical site is just one tooth, it is necessary to flap 3 teeth in order to provide adequate access to the area. If pocket reduction surgery was the only treatment performed in this area, the result would be a higher gingival line. Because this is not aesthetically pleasing, the regenerative procedure will be attempting to rebuild the bone and prevent significant soft tissue recession, avoiding a situation where the patient has a soft tissue defect that could affect speech, aesthetics, or function. This is the crestal incision from the palatal aspect. Crestal incisions are made vertically to the bony crest, which results in a full fit flap with the primary purpose of retaining as much soft tissue as possible. You can see the surgeon is extending the incisions beyond the area of the defect to allow adequate access to the area and to create a large area for blood supply to maintain the soft tissue flap integrity. The clinician is now elevating the flap and reflecting the tissue back using a small periodontal elevator. Clinicians design flaps differently, so they may vary in appearance. Once the flap is elevated, you can see where the crown ends and the root begins. You can also see the extent of the intrabony defect. Periodontal vertical defects are filled with granulation tissues and bacteria. For that reason, it is necessary to debride the defect and ensure a smooth root surface, free of deposits and bacteria. This promotes maximum regeneration. Here, an ultrasonic scaler is used to debride the wound and the root surface. This infrabony defect wraps around the entire palatal aspect of the root and all the way to the mesial surface. The treating clinician is now performing the final root preparation to include smoothing root surfaces. This procedure is performed in order to ensure that all of the calculus and disease cementum have been removed. We know that cementum is very porous and tubular, and we don't know how far the bacteria really penetrate. By smoothing the surface, the area available for rehabitation of bacteria is reduced, giving us a better chance that the root will be biologically and microbiologically accessible. Though the bone regeneration surgery shown here is conducted with a barrier membrane, other options exist for bone regeneration. In this type of bone regeneration procedure, a membrane is used in addition to bone grafting materials to encourage the body's natural ability to regenerate bone and supporting periodontal tissue. The clinician is now preparing the membrane, which is shaped to cover this particular interproximal defect. By cutting the membrane, as we see here, it can lie over the contours of the bone and provide better adherence to the root surface. Barrier membranes are used to keep the flap epithelium and connective tissue away from the regeneration site. This membrane will need to be removed, but other bioabsorbable membranes can be used that naturally dissolve away over several weeks of healing. Keep in mind that wound healing is a race between the flap epithelium and the bone and PDL connective tissue. Epithelium wins every time unless you prevent it from penetrating the graft site. To prevent salivary contamination of the sterile membrane, the surgeon must precisely and immediately fit the barrier membrane to the palatal area of the root where the defect extends. Once the membrane is sized, the bone graft is ready to be placed. There are many types of bone grafting materials available, such as allograft or freeze-dried bone, autograft or bone taken from one part of the patient's body and transferred to another, as well as synthetic bone substitutes and xenografts, such as bovine bone. This surgeon has chosen to use demineralized freeze-dried bone. Studies have shown safety and clinical success with using this bone grafting material, as well as the others mentioned. Once in the defect, the surgeon condenses or firmly packs the bone material. There is a certain density and tension that can be felt when the material is properly placed. The barrier membrane is now placed over the bone graft and sutured into place. The tissue top is pulled over the top of the bone graft and the barrier membrane. The surgeon coronally repositions the tissue, pulling it down so that it is vulnerable to its preoperative location. Suturing is designed so that minimal fixed material lies over the graft material, thus preventing irritation after the implant. The surgeon has chosen Teflon sutures, which has a nice biologic wound healing action. Other suture materials include cotton, silk, nylon, and numerous dissolving suture materials. Post-surgically, a 1-week evaluation visit is important to check for healing process. This is healing at 1 week post-op. The sutures are still intact and are usually removed within 2 weeks. Here is the pre-operative radiograph where you can see the extent of the defect, which again presented as a 7 to 8 millimeter infrabony defect. This is the post-operative radiograph, and approximately 5 months after surgery. You can see that the bone graft has now filled the defect. At this point, the bone graft is not fully integrated, but it is maturing. Approximately 9 to 12 months is needed for the complete maturation of the bone to occur. The expected post-surgical outcomes for bone regeneration procedures include clinical and radiographic evidence of bone fill, although this will not be detectable until after a minimum of 6 months. Reduced probing depth, increased periodontal stability, improved patient comfort, ability of the patient to provide adequate plaque control, and restorative functional stability. Let's summarize the main points of the guided tissue regeneration procedure. 1. This procedure can reverse some of the damage caused by periodontal diseases by regenerating lost bone and supporting periodontal tissue. 2. Several different bone graft materials can be paired with a barrier membrane to stimulate the body's natural ability to regenerate bone. These materials include autograft, allograft, xenograft, and synthetic bone material. The patient should be encouraged to schedule the first post-operative visit at 1 week. Regular maintenance visits should be scheduled thereafter to monitor the graft and to evaluate the patient's ability to keep the area clean.
All right, so for you guys to go there. So this Crawford here, first person that they're saying this thing, first person that they're saying to me, gonna get 5.2 credit. Yeah, we go into it, let's pause, you pass it around, face down, put it face down. This is fair.
You mean I'm cheating? Let's float the person in here.
Thank you.
Shoot.
Like, wait, let's see if this